Welcome back. So, continue from where we stopped. Today, we'll be talking about T wave. So, T wave is the positive waveform that you should see after a normal KRS complex. T wave, it's mostly upright, which is positive. Now, it could have this morphology, which is you can see the smooth transition of the ST segment here. Some abnormal morphology of the T wave include a large T wave. So you could have it as hyperacute like this. You could see this in early stages of myocardial infarction. Now you could have a tall and tinted T wave, just like what you have here. So this could be seen in hyperkalemia. Now you could have a biphasic T wave, and you could also have T wave inversion, which could be seen in acute ischemia and also in some post-ischemic pattern of inverted T wave. You could see very deep T wave like this. You could see them in hypertrophic cardiomyopathy and also in some cerebral vascular pattern. When you have a cerebrovascular attack, you could see some inverted T wave pattern as well there. This is an example of a tall and tinted T wave. You could see this T wave is tall and it is sharp at the edge. This is a perfect example of a tall and dented T wave. So you say a T wave is large when you see it in more than two um, leads. Now we can see this in V4, we can also see this in V5 and V2, V3. You say a T wave is tall when it's more than 10 small boxes, that is two big boxes. You could see this is even taller than two big boxes. So you can say this is tall and dented T wave. This is an example of inverted T wave. You can see the T wave is inverted here. Now the T wave is a waveform after the KRS complex. You can see here it is negative. This is an example of inverted T wave. Now this is an example of inverted P wave. I'm taking us back to the previous lecture. This is a typical example of inverted P wave. So it's different from T wave. In this situation, you could see that the P wave comes before the KRS complex. Then the T wave comes after the KRS complex. This T wave is normal, it's not inverted. But in this situation, we have inverted P wave. There are two conditions whereby you can have this inverted P wave. It could be a junctional rhythm, which is an AV node rhythm, or it could also be that it is atrial rhythm, which means that some cells around the atrium are the one pacing that rhythm. And there's some cells around the AV node are the one pacing the rhythm. How will you be able to know that this is an atrial cell rhythm and not junctional rhythm, which is the AV node rhythm itself? The moment you have a PR segment, then you know this is actually an atrial rhythm. Just like what we have here, we have a PR segment after the P wave. So the moment you have a PR segment is actually an atrial rhythm. But when you have an inverted P wave, just like what you have here, and there's an absence of PR segment, you'll be thinking of junctional rhythm, which is the AV node rhythm. Because AV node rhythm can appear as inverted P wave or absent P wave. This is an example of inverted P wave here. You can see now in left atrial enlargement, you can see that the P wave is wide. When you count this is 1, 2, 3. It's greater than 2.5. So, but it's not as tall as 2.5. So you will say it's a left atrial enlargement. And you can see your biphasic P wave here. So these are different morphology of the P wave. Now this is an absent P wave. You can see that there is no P wave before the KRS complex. You could see a flat line before the KRS complex. So in this situation now, you could see that there is a bundle branch block here. There's a bundle branch block here, which is the reason why you're having a wide KRS complex like that. So this is not tachycardic. You can see, I'll teach you how to calculate heart rate, but there's a trick to that. The moment the big boxes between the RR interval is less than 3, then you say this is tachycardia. The moment the big boxes between the RR interval of a regular rhythm is greater than 5, you say this is bradycardia. Now the moment is between 3 to 5, you say it's a normal sinus rhythm. Normal rate, when you calculate your rate, is going to be between 60 to 100. This is an example of absent P wave as well. You could see that you couldn't see any P wave here, any P wave. So atrial fibrillation is one of the conditions whereby you see absent P wave. One fact about atrial fibrillation is they call it irregular, which means that you're not going to see a P wave, okay, or you're going to see a regular P wave, which are fibrillatory waves like this, and there will be RR interval differences like irregular RR interval. So it's irregular P wave, irregular RR interval. You can see that the distance from here to here is different from here to here. So it's having two major um, characteristics: abnormal P wave and also irregular RR interval. So this is an ECG that shows atrial fibrillation. You can see the RR interval is not regular. You can see this from here to here is wide. From here to here, this is your R wave. This is R wave. So R to R to R, that's what we call RR interval. So you could see that they are fibrillatory waves. These fibrillatory waves, you see them more in V1 and in lead 2. This is a lead 2 rhythm strip. The same lead 2 you have here is what you have here. Now, this is another example of wide KRS complex. You could see the wide KRS complex here. The KRS complex is wide. So this is also as a result of this is a right bundle branch block. It's more like right and left bundle branch block. When you have this pattern at your V1, you say this is a right bundle branch block. When you have it in V6, V5, you say it's a left bundle branch block. You can see this wide KRS complex. You can see the wide KRS complex in V1 especially. So this is an example of a wide KRS complex as well. In this situation, you can see that it is wide and it is tachycardic. The big box here is less than 3. You can see it's really one and a half or even close to 2, but it's not up to 3. So this is what we call VTAC. You can see the wide KRS complex. You can't even see a P wave. So there's absent P wave or retrograde P wave and wide KRS complex. Wide KRS complex means that the KRS is wider than 3 small boxes or equal to 3 small boxes in this situation, and that is like 120 milliseconds or 0.12 seconds. So you can see that it is wide. From here to here is wide. So this is VTAC. It's still an example of wide KRS complex. Then what you have here, you could see PR interval. This is a lecture on PR interval. Counting this PR interval, normal PR interval should be between 3 to 5 small boxes. That is 0.12 to 0.20 or 0.2. Anything less than 0.12 is actually a short PR interval. Anything greater than 0.20 is a prolonged PR interval. So this PR interval here seems prolonged because this is up to like, this is more than 5. This is about 6. You can see this is a full 5 and this is about 1 or thereabout. So this is a prolonged PR interval. So for this, I'll call this a first degree heart block. Why? Let's go to the next slide. So when you have a prolonged PR interval, you'll be thinking of heart block. The heart block could be first degree, second degree, or third degree. Let's start from first degree. So what you notice in first degree heart block is that the PR interval will be more than 5 small boxes. So let's count here. These are about 5 and these are about 7. And it's going to be consistent. You will have it 7 here, you will have it 7 here, 7 here, 7 here. So it's going to be consistently prolonged like that without a drop in KRS complex. So when you have this, you say it's a first degree heart block. Now, the next degree of AV block is your second degree heart block. Second degree heart block is divided into two. So you have the type 1 and you have the type 2. For type 1, what we notice is that there will be prolonged PR interval, definitely, but it will be progressively prolonging. Like what you have here is lesser than what we have here. You can see the duration, then here is wider. Then one thing that is consistent with second degree heart block is that you have what we call occasional drop beat. Like after like maybe every 3 cycles like this, you have a drop beat. Drop beat means that There will be a P wave, but there will not be a KRS complex. Then you will now have another P wave. Then the cycle continues like that. Just like there will be a missing KRS complex. Just like imagine that in this, like in this ECG now, imagine that you suddenly, where's my pen? Okay, so let's go to the next slide. What we have here is second degree type 1. Sorry, this is type 2. This is a type of graphical error. This is type 2. So what you have in second degree type 2 is that the PR interval is prolonged, but it will be fixed consistently like that. It's not going to be progressively prolonged. Now, you will not have a drop in KRS complex. This is a perfect example of drop in KRS complex. You have a P wave, but it's non-conducted. You can see there's no KRS complex. Then you have a P wave, the cycle continues like that. Now, the difference between first degree heart block type 1, second degree heart block type 1 and type 2 is that the block is actually above AV node for type 1. But for type 2, the block is below AV node. So type 2 is more dangerous than type 1 because below the AV node is your ventricle. So it's more dangerous at that end. Now, this is a third degree heart block. One special thing about that, the one unique thing I should always remember about third degree heart block is that the RR interval, like what you have here, is not going to be in relationship with the PP interval. Like now, the PP interval is the same. You can see PP, 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 PP. This is your P wave. But after a P wave, there's supposed to be a KRS complex here. There's no KRS complex. There's another P wave. Then it's like consistent drop in KRS complex. So this is a very dangerous rhythm that you need to watch out for. When you have a KRS complex, what's it called? A PR interval that is less than 0.12, you should be thinking of Wolff-Parkinson-White syndrome, WPW syndrome. But one thing about Wolff-Parkinson-White syndrome is that you are likely going to have this delta wave. It might not be like this. It might be like, you know, in another pattern, but this is the most common presentation of it. So you have a delta wave with a short PR interval less than um, 0.12 seconds. So Wolff-Parkinson-White syndrome simply just means that there's an accessory conduction from the atrium into the ventricle. They call it bundle of Kent. Yeah. So this pattern is like an alternate pathway for impulses from the atrium to get to the ventricle. So you are going to have this kind of um, delta wave. So it depends on the pattern. It could actually be, you know, in a particular fiber direction or the other fiber direction. So it's actually a deeper topic, but most times when you see this delta wave and you see short PR interval, you'll be thinking of Parkinson-White syndrome. Another condition that you can have this is also injunctional rhythm. Definitely the P wave is inverted injunctional rhythm and there's no PR segment. So your PR interval will be short. Now, pericarditis is also one of the things that you will actually need to learn when you are looking at the PR segment or PR interval. Now, in pericarditis, we might notice that the PR segment or PR interval, PR segment in particular, is actually depressed or elevated. So that is in less than 1 week when the patient has pericarditis. But later it gets normalized and T wave inversion takes over. So you can have a downsloping of TP segments. They call it spodic sign. You know, it's best seen in V4, I think V4, V6, thereabout. So with this, you can be able to say a patient is having pericarditis. The other thing, echo is a very good test, but not really specific for pericarditis. I think MRI CT scan should do justice to that. But this is a perfect topic, PR depression. Now, many people used to use PR segment to know if your ST segment is elevated or depressed. So this is actually a pitfall. So we don't use PR segments. We use the TP segment to know if our ST segment is elevated or depressed. This is the ST segment. Normally, the ST segment is supposed to be flat like this, the same line with every other. But when it is depressed, you can see it's below the line. So this is what we call ST segment depression. We have three types. We have the upsloping. You can see this is going up. We have the downsloping and the horizontal. This downsloping and horizontal are dangerous, but this upsloping, you might see it as a normal variance in some patients. ST segment elevation in the other hand, you can see that this is the ST segment here. This is a TP segment, this is a PR segment, TP segment, but here you see the ST segment is elevated. So this is what we call ST elevation. ST elevation. Now it has two types. You can see this convex and concave. So this convex is the one that indicates myocardial infarction. This convex could be early repolarization pattern. So in a nutshell, we have been able to summarize, today's topic. In the next class, we will be going into cardiac rhythm, and also we would like to talk about the QT interval because it's very important also. Thank you for joining the class today. See you next week.